Hello, welcome to my presentation on selective mutism. So to start with the agenda, we're going to first look at what is selective mutism. We're going to look at the literature review, see the instrument used for diagnosis, then see some of the treatment options, then go over the differential diagnosis, and then end off on a case presentation. So first, what is selective mutism? So it's mainly characterized by an individual voluntarily not speaking. So to be more specific, in order to be diagnosed with selective mutism, you have to meet the criteria for the DSM-5. So starting with criteria A, the individual fails to speak in specific social situations, but they can speak in others. For criteria B, this impacts the individual's educational or occupational achievements or their social communication. For criteria C, the symptom occurs for at least 1 month. For criteria D, it does not occur because of lack of knowledge in the language or comfort speaking the language. Then lastly, for E, it is not explained by communication disorder, nor autism spectrum disorder, schizophrenia, or any other psychotic disorders. So now let's look at the prevalence and course. So selective mutism is a rare disorder and is mostly found in young children compared to being in adolescents and adults. So individuals who have to speak their non-native language are at greater risk for this disorder. So the onset is before age 5, but is mostly discovered during school age, so when a child begins going to school. According to the APA DSM-5, clinical reports suggest that many individuals outgrow selective mutism. So next, let's look at the prognostic factors. So starting with temperamental, it's negative affectivity, behavior inhibition, and parental history of being shy, social isolation, and social anxiety. Now for the environmental, it's social inhibition by parents and parents being overprotective and controlling of their child. So now there is a genetic factor with social anxiety, but in addition, for auditory efferent neural activity, this is when the individual perceives their own voice as being peculiar. Now let's look at the culture related. So individuals who migrated to another country and who do not know the language or comfortable speaking the language, and they refuse to speak the language because they're not comfortable and they don't know the language, they would not meet the criteria for selective mutism. So just because a person don't know the language and they're not comfortable speaking it, does not mean that they have selective mutism. So now let's look at the literature review on selective mutism. So starting with the etiology, so selective mutism was identified in the 19th century by a physician named Cosmo in 1877. So there has been a few name changes. So starting in 1877, it was named aphasia voluntaria. Then in 1934, it was called elective mutism. Then in 1994, it was called selective mutism, which is what we know it as today. So though there has been like a few name changes, it does still have like a consistent meaning of the individual choosing or selecting when to not speak. So as stated before, it is a rare disorder. Selective mutism is a rare disorder. It's estimated, but this estimation may even be lower, that only 0.47 to 0.76% of the population have this disorder. So because of this, there may be a challenge for research studies, specifically for the sample numbers, because the population is so low in number, that means their sample numbers are also pretty low. So now let's look on the theories in selective mutism. So how does selective mutism come about? So starting with the psychodynamic theory, it is believed that selective mutism is a coping mechanism to dealing with anger and anxiety and represents behavior intended to punish the parents. The second is behavior theory. It is believed to be a symptom of anxiety where the individual responds unconsciously in a language-based form of behavior inhibition or as a defense mechanism. The next is social phobia and social anxiety. It is believed that selective mutism is a variant of social phobia and is characterized by excessive social anxiety. For the family systems theory, it is believed that selective mutism is a results from the neurotic relationship with the parents. So what this means is that the parents have a controlling behavior and this leads to the child to develop an unhealthy and tense attachment characterized by extreme interdependency and subsequent fear and distress. Next, for post-traumatic stress disorder. So this develops mutism in response to a traumatic event that the individual has experienced. Then lastly, to end off with developmental psychopathology theory. So it is believed that individuals with selective mutism have a predisposition of being anxious, having a language deficit, and experience teasing from school because of their language deficit. And all these things combined may lead to avoidance and showing symptoms of mutism. So now let's look into research on prevention and intervention. So Buss and Downey did a study on three-tiered approach to prevent and intervene for selective mutism. So starting with tier one. So tier one is before any signs of selective mutism is shown. So there's no signs or at risk or diagnosis of selective mutism. So first is to provide the parent or caregiver newsletters and trainings on the identification and prevention of potential anxiety problems. The next is the school-wide oral communication strategy. So these strategies are maintaining the expectancies for speaking, providing opportunities to respond, and to have wait time responses. And then lastly, to minimizing the reinforcement of nonverbal communication. And then lastly, for tier one is preparing the preschoolers and the families for their transition into the kindergarten grade. Now getting to tier two. So tier two is for children who are at risk to develop selective mutism, but they don't have selective mutism or don't meet the criteria as of yet. So first, we want to identify who may be at risk. So an example could be children who have anxiety-related behaviors, such as already being suffering some separation anxiety, for example, from their parents. Next is child-focused oral communication strategies. So this is maintaining expectancies for speaking, providing opportunities to respond, having a wait time response, and then minimize reinforcement of nonverbal, similar to tier one. The next is group therapy. So you gather other children who are also at risk to developing selective mutism, and you provide group therapy for these group of children. Then lastly is contingency management. So this is when the teacher uses positive reinforcement with verbal behavior, but then they will ignore the nonverbal behavior. So they're only showing attention to the verbal behavior. So lastly is tier three. So this one, the child has already been diagnosed with selective mutism. And for this intervention is just treatment for selective mutism. So some examples that the authors give is psychopharmacological therapy and behavioral and cognitive behavior therapy. But we'll get into more details about other therapy options. So here's the instrument used for diagnosis. So selective mutism questionnaire is the instrument that's used, right? So according to Letamendi, the selective mutism questionnaire is the only available instrument developed to measure a child's frequency of non-speaking behavior across situations in which the children are expected to speak. For example, school, like children are expected to communicate during school. So here's an example of what a selective mutism questionnaire would look like. So as we see this document, we see this is what a selective mutism questionnaire would look like. So we see that we have the child name and the parent is also involved during these questionnaires. So we see the different settings that they're going to talk about. So what is the child's behavior at school? What is the child behavior at home or with family? What is the child behavior outside of school? So the doctor, the park, and other settings. And then lastly, in one of the most important ones is when the child has this behavior, how does it interfere with them or how does it distress the student? So this is an example of what the selective mutism questionnaire looks like. So next, let's look at the treatment for selective mutism. So cognitive behavioral therapy is stated to be the most effective treatment for individuals diagnosed with selective mutism. So Orbeck conducted a study in which lasted for 5 years. So in the study, they want to test the effectiveness of school-based cognitive behavior therapy on 30 children who were their sample, who were shown to have selective mutism based on the results on the selective mutism questionnaire. So results after 5-year follow-up, so these children have had 5 years worth of cognitive behavior therapy. It was found that 70% of participants no longer met the criteria for selective mutism. 70% spoke freely in some settings, but not all. And then 30% continued to fulfill the diagnosis for selective mutism, so they met every criteria for the 13%. So here's some other treatment options. So we have psychodynamic therapy, which is specifically called individual play therapy when you're dealing with children. Next is behavior therapy. So as we've seen before with the teacher, so they will provide verbal and non-verbal negative reinforcement that sustains selective mutism behavior. And then next is family therapy. Then the last one is medication-based intervention. So these are antidepressants, which is mostly used for selective mutism. So this is the medication that's provided for this diagnosis. So let's go over the 4 different differential diagnoses. So the first one is silent period in immigrant children learning a second language. So the problem with this one is that they can only meet this criteria for selective mutism if they fail to speak in their native language and non-native language. So if they're able to speak in their native language, they in every situation, then they do not meet the criteria for selective mutism. So next is communication disorders. Some examples of communication disorders is language disorder, speech sound disorder, child onset fluency disorder, also known as stuttering, and social communication disorder. So these disorders happen in all settings and not just specific social situations, like selective mutism. So they will have this disorder in every situation, doesn't matter where they are. So next is neurodevelopmental disorders, schizophrenia, and other psychotic disorders. So these disorders can lead to challenges in social communications and speaking in appropriate situations. But the difference is individuals with selective mutism does not have the capacity to appropriately speak in some social situations um, at home, but not all, such as like not being able to speak at school. Then lastly is the social anxiety disorder. So in some cases, some individuals may meet both criteria for selective mutism and social anxiety. So it kind of just depends on the criteria, since there is like association between selective mutism and social anxiety disorder. So now to end off is the case presentation of Vignette. So here's a scenario. So Anna's a 6-year-old girl. This is her first time being in elementary school. Anna's teacher, Miss Jones, quickly noticed that she did not participate in class and in fact has never spoken a word in class. Miss Jones assumed that Anna just needed some time to adjust to the school setting, but it has been 5 months since school started. Miss Jones decided to further investigate and learned that Anna did not speak to any staff or students during recess or at lunchtime. Ms. Jones decided to speak to Anna one-on-one and asked her what did she want to do today. And as expected, Anna did not respond, but did point towards the coloring books. Ms. Jones spoke to Anna's parents about this concern, and Anna's parents were actually surprised because Anna actively speaks at home and even in a car ride at school. So what this scenario shows is an example of a child who does meet the criteria for selective mutism, right? So they're failing to speak, not only to one person but to everyone in the school setting, but they do speak at home, and with the parents, and even in a car ride. So we see that there's a difference in settings that the child chooses or voluntarily speaks and voluntarily does not speak. And also this has been going on for 5 months, so it's not an adjustment issue. It's just that this is what the example of selective mutism is, when they have it for more than 1 month. So now to end off, this is our reference. So if you need any of this information, it's here. So thank you all for watching. I hope you enjoyed this presentation.